Anupam, please initiate the Facebook.
रोहन इसको पर YouTube पे शुरू करा दो.
Yes sir, करवा दिया sir.
We are live now.
Very good evening, everyone. We welcome all back to another chapter of the youthful web series under the aegis of IRSI. The topic for the session is of great importance to all of us, especially those who are interested in knowing all about retina. The topic for today is decoding facts and myths of retina practice. Our aim at the end of the session is that we learn everything about recent protocols, treatment patterns, the facts of OCT, and how to educate yourself in the current world of online conferences and webinars. We've invited the greats from the field of retina on the panel today to help us decode the various facts and myths of retina practice. We welcome our IRSI President, Dr. Himanshu Mehta, to inaugurate the session, please.
Good evening, Rohan. Thank you very much for inviting me for a lovely session on retina. Retina is something very, very dear to me also. As I put it to everybody, I do cataract refractive, but I train retina. So retina is for my SOUL soul, and cataract refractive was for my SOLE soul. That's how I'm surviving right now. So something which is what is a taboo, if you start doing it and regularly start seeing a few cases, or you do a few vitrectomy on a guinea pig, you will get the confidence of handling the vitreous for all anterior segment surgeons, which I've been mentioning. And the kind of webinar that you're keeping, the level at which it is being sold, everybody can go back, can rewind, have a look at what's going on and the current updates. There's no reason why everybody should not be giving intravitreals themselves. There's no reason not to do medical retina by people. It's something so very simple. And once you get onto it, you will love doing it. And thank you for holding such things and information so that we can always rewind, review, learn, react and interact with everybody and all the great people. Thank you, Dr. Lalit Verma, for spending some time and for this meeting, and Dr. Mishra, Dr. Luthra. Everybody has been kind enough to share their experience on retina, and of course Srinivas is always smiling and there with us to see that we are the medical field. You know, he has a lovely smile and he comes and explains everything so beautifully that it's fun to have him there. Anshika, out of your residency, despite being on call, you're here. That's nice to see you here. And thank you very much, Rohan. All the very best, Dr. Pooja and Rohan. Let the seminar begin.
Thank you so much, Dr. Mehta, for your kind words. We now welcome our first speaker, Dr. Divakant Mishra, who is a vitreoretinal ocular oncology and ROP consultant at the IEQ Super Speciality Eye Hospital, Lucknow. He holds the post of the General Secretary at the Young Ophthalmologist Society of India. He has won multiple international and national awards along with multiple publications. It is a pleasure to have you on board, sir.
Thanks, Pooja. I'm having some issues with my sharing. Can we go ahead with Dr. Srinivas, sir, and then I can come in second. Thank you.
Srinivas, is that okay with you? Can you start? You're muted, Srinivas. Yeah, is that okay with you? Can you start?
Sure.
Okay, thanks.
So it's my pleasure to introduce Dr. Srinivas Joshi. He's the Director of Research and Community Service at the Joshi Eye Hospital. Dr. Joshi has completed his training from the United States and Toronto. He's the first Indian to be trained for the artificial retinal implantation and also holds a special interest in artificial retinal algus too. Dr. Joshi has spoken at various national and international conferences. He has a keen interest in teaching and has many fellows working under him. We welcome you, sir.
Thank you. Thank you so much, Dr. Mehra. If you can give me a minute. Am I audible?
Yes, sir.
Just give me a second. Okay, so good evening, friends. At the outlet, I would like to thank our organizing secretary, Dr. Pooja Mehta, another organizing secretary, a dynamic smiling person, Dr. Rohan Mehra, Dr. Tushya, Dr. Anshika, the young team, that's the youthful team of the IRSI headed by Dr. Himanshu Mehta, Dr. Amar Agarwal, Dr. Mahipal, and Dr. Gaurav Luthra. So with this, I would like to share my screen. I hope the screen is shared.
Yes, sir.
Okay. Thank you once again. And my topic today, I'll be speaking on the webinars and conferences. I'm sure that most of us are flooded or bombarded with too many webinars nowadays. And here it comes. Who doesn't like to thank Dr. Himanshu Mehta? You know, the big B himself has thanked. That means the whole nation would like to thank Dr. Mehta for his wonderful work. It's not only just Amitabh, but the whole country would like to thank. And thank you, Dr. Mehta, for this wonderful things, what you are doing there back in Mumbai and all the organizing team. So coming to the topic proper, can I live without conferences and webinars? So there are two kinds of personalities, as we have all known. One is the extrovert, another one is the introvert. If you see this, Bill Gates, Jeff Bezos, Elon Musk, they are actually the well-known introvert leaders, right? So let's speak about most of us who are not so seriously introverts like these people whom I mentioned before. So what will you achieve as an ophthalmologist? We would like to have a stable practice, fair amount of money, and a normal routine life. So now coming to live conferences versus webinars. We had a beautiful debate series between Dr. Honavar and Dr. Rohit Shetty. And these are the few glimpses of that. If you can see here, the sum total of travel associated with attendance at one large academic conference can release as much CO2 as an entire city in a week. It's almost 3 tons per person. And the carbon karma, an average 4-day with a 1,000-person national conference generates around 3,000 tons of planet. And an AIOS conference would generate about 30,000 tons of CO2. But on the contrary, what is happening now? There's too much of social distancing. If you can see here, there are more than 1,000 articles now on the social distancing. And now it's been proven that it is causing depression, anxiety. You can see the pictures here causing more confusion, draining of the battery kind of symbols. So what are the benefits of meeting people? It improves the mental health, confidence and self-esteem, reduces the risk of Alzheimer's is what me and Dr. Rohit keep speaking about. And he's doing more and more research on that. And I'm sure that it must be true that physical conferences definitely gives a boost immunity, increased brain health and promotes the purpose. So webinars and virtual conferences, yes, definitely it's accessible to anyone, economical to organize, low carbon footprint, eliminates travel, speed, more value at a fraction of a cost, chat rooms, level playing field, anytime access, environment friendly. But definitely live conferences have its own charm. You know, meeting old friends, colleagues, sharing a meal, chance to meet the inspiring figures in your field, and nothing can replace the hands-on surgical training and demonstration. So can I actually be this? So how can someone make the best use of conferences and the webinars? The most important, I would like to tell all my young colleagues, the first important thing, if you want to be different from others, then that's the research. That's the publication. Your publication in reputed journals will attract organizers to call you as a faculty. It will be your contribution to the scientific world. Please remember that. and your name is there to stay for long. And definitely those who are applying for any other fellowships or job, it definitely boosts your CV. Opportunities for VR surgeon, if you can see that there's a major list of retinal related journals here, the various society which you should be a member of, especially the American Society, Retina Specialist, European Society, Federation of American Society of Experimental and American Academy of Ophthalmology. These are the few of the popular journals. Apart from the IJO, which is being very ably led by our own Dr. Honavar, we have the Retina, we have the Progress in Retinal and Eye Research, we have International Journal of Retina and Vitreous. And if you have any interesting case to share or something which is not so commonly seen in day-to-day practice, then definitely send it as a newsletter. This you can see the Retina Today as a weekly newsletter or a monthly newsletter. The next important is paper and poster presentations. My dear young colleagues, a good presentation will provide an opportunity to get noticed. It provides a chance to interact with the topmost leaders in the same field. For example, someone sees a great innovative presentation, a technique, and definitely they get inspired. They can spread the knowledge. And most importantly, it adds to their own personal modification ideas to make it even better. Who knows that the person who is sitting in the crowd may be your future employer, or maybe a partner, or maybe your professor, your mentor. So a memorable presentation may be the edge that made them select you over the others at the time of fellowship interviews. So what are the various opportunities for the VR surgeons? In the ASRS, we have Retina Image Bank here. You see the beautiful images, what you capture can definitely be showcased. So let the world know what you're doing. See, these are the few of the important images, and I'm proud that my own friend, Dr. Vishal Agarwal, who bagged the best retinal image of the year. These are the various other pictures you can see. So nice pictures. It's always better to see them. And these are all the award-winning pictures. And joining these kind of societies, like as I described, is the APAO, American Academy, European Vitreoretinal Society, Asia Pacific Vitreoretinal Society, will definitely give you an edge internationally. And please do not forget our alma mater, our mother society, who is none other than the All India Ophthalmological Society. And we welcome you all for AIOS 2021 Kolkata. Next comes the video presentations. The video presentations at the conferences are the one which brings the notice of the other ophthalmologists, especially in case of retinal surgeons, referrals, if they want, in fact, to tell you frankly, if you showcase your retinal surgical skills, then the people who are around you who want to refer will definitely think that you're a very good surgeon, and they will definitely increase your retinal practice. Platform to showcase your skill, what you're good at, and what you're doing differently than others. Just to give a glimpse of my story, this is the 4th year I bagged the ASRS Rhett Buckler Award, the prestigious Rhett Buckler Award. And this time it was a surprise that it was the best of the show. And I would like to give half of the credit to my colleague who was a fellow, now who is a consultant, who is Dr. Giriraj Vibhute. I did my surgery, but the animations, what all the things are required to make it necessary, a good video editing and animation are actually done by the youngsters. You people have a superb attitude. You know the technology very well. Just you need to make in a good collection of what you're doing, and the good use of the technology will definitely make you bag more and more awards. And now you can see you get your names, or your colleagues, your fellows' name get published in the international journals or the international websites. And definitely we have a prestigious in All India Ophthalmic Society CS Reshmi Award, Rema Mohan Award. So it's always a kind of boost which you should try to do. I'm not telling that you should apply for the sake of award. You should keep trying and trying. If you get an award, it's always a boost for you, and so that you can fine-tune your skills further. If you look into the ASRS Society, there's so many awards like Pyron Award, Founders Award, the ASRS President's Young Investigator Award, the PACO Award, the Crystal Apple Award, especially for only early career section. That means the members who have been in practice 7 years or less. See, there are so many awards these international and the national societies are doing to attract and promote and to reward these youngsters. We have our own Vitreoretinal Society of India. VRSI is now calling for interesting images on the retina. When I first looked at this Wyburn-Mason syndrome, I was stunned at see this picture, and all credits to Dr. Deepak Bhojwani. Such a nice, wonderful picture, and the whole nation sees it, isn't it? The images competition, who have the best images. Now they are felicitated as the winners, first, second, and third. It's nothing but to give the youngsters more and more boost so that you can do more and more good job. Now, the online trauma video competition done by the Ocular Trauma Society of India. Again, our fellow Dr. Giriraj, he won one of the best video. So he was so happy, and now the whole institute is behind him asking how to make the edition and the animation. The other part, definitely you should look into these part. That is, now we have from the academic and the research, we have take a break session where we invite people to give a 1-minute video pearl, clinical photographs so that it gets published. And so that more than 10,000 viewership is there for these kind of, take a break session. And not to forget our own Dr. Lalit sir's idea between CCFS snippets, the whole picture, the whole lesson can be taught in few photographs with a few words, so that the residents or the fellows can definitely, it can be a refreshing kind of thing, just to brush around so what they have read, and definitely it helps in their clinical practice as well. Now, if you become a member of these Vitreoretina Society, your own parent bodies, then definitely you can see the Vitreoretina job opportunities here for the people who are looking for the vitreoretinal job. See, where are the current openings, in which all institute are there, what all requirements are there. It also helps in your current openings and the job opportunities as well. Now you have the different rounds, the Yanuzi round, which is picking up, and our own moderator, Dr. Neil Bressler, who has been the moderator a couple of times, where they invite the abstracts. So this is the podium where I request youngsters to please present interesting cases in such podium. And you have the ASRS grand rounds, which actually started in March. And you have late right retina, the Joshi initiative, where Diva is in full smiles, Diva, Karan, and Purva, and many others are doing a wonderful job in the kind of Joshi, where they're trying to educate more and more, bringing in the experts in the field and try to share in their knowledge. In the ASRS early career section, they also invite you to submit a case for the Retina Challenge. Fellows Grand Rounds is there. Submit as a spotlight case. Submit an innovative retina surgical video. See, so many options are now available for the younger generation to showcase their talent. And then we have Fellows in Training section. You can see the FIT videos, early career mentoring program, the Retina Career Center. You have the career planning, grant opportunities, etc. Now, I asked Pooja, she said, sir, a little bit about the international fellowships also would like to be covered in this topic. So observership, definitely it helps you, because observership internationally, it's a dipstick test before doing any long-term fellowship, because it is easy to get, needs advanced application. Some institutes ask for payment, but tourist visa is what is very much needed. If you look into the long-term clinical fellowships abroad, then definitely a few of them ask for USMLE, and it's a strong CV and recommendation is required because it's highly competitive. You get a good exposure. Some of them are paid fellowship, but most of them offer you the stipend. And do we really need it? Yes, I think so, because it understands the different work culture, helps find a focus area, helps find different mentors. You see your mentors here. You can just have a glimpse of what is going on around the world. It broadens your horizon, widens perspective, provides the cutting edge knowledge, and stimulates to think different and do different. There are various other, if you don't want to go outside, you want to sit here, definitely there are a few other fellowships like Royal College, Edinburgh, Glasgow, and these are the various websites. You have the ICO, there's different types of ICO fellowships for the people who are just finishing their residency or just doing the Indian fellowship and they want to go in more ahead. Then you have the Retina Helmerich fellowships where they award you $25,000 timing. So is it really required? You just need to discuss this with your family and your mentors. I always keep telling my younger generation, please have a role model. Please have a role model, any teacher who would like to emulate, ask them. And definitely ask your own retina colleagues or your own teachers that whether should I finish before fellowship in India and then apply abroad? How much time do I have? Is it really worth applying for an international fellowship? It might not be. So it all depends upon your tailor-made approach, how you are, in what place you are, what practice you are going to do. So you have to make your own recipe. And does it add anything to my qualification? You just need to think about it. Should I just stick to 3 months fellowship? When should I apply? These are all the questions which keeps coming post-residency. Definitely going in for these conferences, it's not just about learning. but definitely you will get to know more about what innovations is happening in the industry. So the top 5 improving efficiency. See here, these are all the youngsters who just you not see them, but you also see them how they innovate, what is their innovation, and how is it helping to our clinical practice. When you go into the wet lab, you get to operate the simulation-based operations where you can do a wet lab, where you can see the Centurion, the high-end the microscopes like the Ingenuity, RTO 300, 3D imaging system. Then you have the intra-op OCT system. You have wonderful gadgets. No, definitely you can just have a hands-on on them, and if you like them, then definitely you can go ahead with them. So I would like to tell all our younger colleagues, state conferences first to begin with are a very good platform, because some conferences have that they have a domicile purpose, then you are stuck there. But those who do not have the domicile, then that's an opportunity for you to go ahead and apply. Keep a track of submission dates, guidelines, format, resolution for the videos, use of these gadgets. I'm sure that you all must be doing using Google Assistant or Alexa. Definitely avail travel grants, competitions through quiz, papers, videos. Many conferences offer travel grants to the winners, present at the conference, grants from the institutions, and you have various travel grants. And I think Diva it's his favorite topic, where he has spoken a couple of times about what are the travel grants, and he himself has got many travel grants. So this is the one which we started in Karnataka when I was the chairman scientific, the student of the year. The winner gets 1 lakh rupees as the travel grant to attend any international conference once he gets the best paper award. So this is the few glimpse of that. So when at conference, please make sure visit the trade area to know what's latest and what's trending today at the present time, to know the cost factors for future planning. Don't be shy. Walk up to the leaders. Chance to meet the expert. Make an impression that will last. Improve the chances of fellowships. So my first experience, I'll be finishing in a minute. My first presentation at RetNet and then presentation during observership at Toronto really helped me to get a long-term fellowship. Best video award at ASRS definitely boosted me. And these are the few of the things which Rohan was telling. It's the topic which is very close to my heart is the Argus 2 retinal implant. We did it with Dr. Robert Deveni, my mentor. And this is the whole team which we operated on 2 patients during my fellowship. And you know what? I was taken aback when Lalit sir chose me and he said, Srinivas, you have to come and give a keynote address. Just after my fellowship, and giving a keynote address at the prestigious All India Ophthalmic Society is something which, it just woke me up and said, yes, we have to do something good. And many thanks to Lalit sir for picking up what we are doing. And I'm sure that you will definitely, if you're doing good work, you will be picked up. So don't attend a conference just because my friend is attending. It's such a cool place to just get away from the routine. Remember, it's not the strongest of the species that survive, nor the most intelligent, but the one most responsive to the change, said by the Charles Darwin. And you know what? It applies even today. This is my last slide. When Steve Ballmer, the Nokia CEO, when asked the question during the press conference, he said, we didn't do anything wrong, but somehow we lost. When the analysts looked into it, they said they missed out on learning, they missed out on changing, they lost the chance of survival. So my dear friend, the message of the story is, if we don't change, we shall be removed from the competition. The advantage you have yesterday will be replaced by the trends of tomorrow. Those who refuse to learn and improve will definitely one day become redundant and not relevant to the industry. Thank you very much once again for this wonderful opportunity.
Thank you so much, sir. Thank you so much. That was very stimulating. I would request Dr. Manshu sir and Dr. Lalit sir for any comments on the talk.
Dr. Lalit, please go ahead.
I told you that worth listening talks will be by Srinivas and Divakant. Although Srinivas had 132 slides, but he did not take much time in running through all of them. When Rohan was introducing, I wanted to speak one line about Srinivas because when I was chairman of the scientific committee, I actually did not know Srinivas Joshi, honestly. So I actually, came to know about him through a website. That is the reason in my first year of chairman of the scientific committee, he was a guest speaker. He was an invited faculty. So the reason I think he put it very nicely that apart from your surgical skills, apart from your, critical Google knowledge or whatever. What needs to be learned is how to be different. And the reason I invited him without knowing that, actually at that time I did not know that he is part of that Joshi family. And I invited him as a guest faculty and first guest faculty of front photograph. And I was very proud to, then know him and then, I've known him. So my take is that, you see, he has enumerated a lot of things. It cannot be easy for all youngsters, Rohan, to follow each of them. But you have to begin. What I believe is in life, what gives you happiness is satisfaction of doing a good surgery. But all people who do good surgery may not get noticed. Therefore, he has listed. Today, Himanshu has become a celebrity by operating on one of the topmost VIPs in the country. Not that Divakant or Rohan can't do a cataract surgery, but operating on one person gives you that level of confidence and hence the exposure. My mentor, Dr. S.K. Tiwari, he used to give us chance. I remember, operating on presidents and even, a lot of journalists. Because operating on one top VIP will give you so much of confidence that, if you operate on 100 of them, routine patients will not. Because you are accountable, you are being observed, you are being watched. So that, and the other thing what Srinivas touched very nicely was how to be different. How to be different. You have to, the first slide of his research and publication. When we were in RP Center, all my residents after 5:30, other thing I wanted him to add was that life for all youngsters should begin at 5 or 6 p.m. Not that 9 to 5 year job you're done and you go back home. Begin at 5:36. When I was in RP Center as a faculty, all my residents will, concentrate in my room at 476 was my room number. Everybody will come there. We will interact. Kya dekha, kya kiya, and allot some paper, publication, case report, image, whatever. It will be done within a stipulated time. And all of them, believe me, today are full professors there, and I'm so happy, very, very happy to see their achievements. So what gives you a kick? Not a routine surgery or this thing, but what gives you a kick once your paper gets accepted in retina or ophthalmology, or you operate upon a top VIP very successfully, and he writes on a Twitter note that I'm so happy. It's not Himanshu, don't it's not that just because you are there, I'm saying. I wrote to you separately also. The other thing which Srinivas very nicely touched upon is whether in India or abroad. So my take is, as of now, every youngster should make it a point to visit abroad. It opens up a plethora of your, the horizon. That means your way of thinking, your approach. You see, when I was in California, the only thing I learned from one of my mentors, David Kang, was how to approach a patient, how to talk to a patient, and that changed the entire thinking. Then I was in Boston for PDT and TTT training. So Ilyas Vaishal was there, and a lot of other people were there. And the approach, I used to just observe. You see, Srinivas, observation is a great teacher. Like you were first assistant to your mentor in that, bionic eye, that teaches you a lot of things. You have to have an eye on observation. The other thing which I would like to add is all of you and all of us, which I still keep doing, is read every day. Read every day. At least, even if you read one article of your interest, read every day, make notes. Reading makes half a man, but writing makes a perfect man. Keep writing something or the other. Today, before I came to Rohan's, invite here, my fellow, I gave 2 homeworks to her today. So it's a story. For us, it keeps going on and on and on. And believe me, all these seminars and conferences make a difference. Start at the smallest possible level. My first journal publication was in Patiala Ophthalmic News. but subsequently we published in ophthalmology, archives of ophthalmology, IOVS, all the journals. So I think Srinivas has done a great job. It was a really eye-opener. I hope we deliver this talk in all sectors in the country so that all the youngsters motivated. Believe me, youngsters today are doing much better than job than us. Surgically, they are more experts than us. But they have to be properly tuned, and a lot of them may not be interested initially. But believe me, एक acceptance आ जाए ना publication का, so it opens up the hearing. 10 publication करने का और मन करता है. Thank you, Srinivas, for excellent talk, and thank you, Himanshu and the young team of Rohan's Puja for arranging it very well.
Thank you so much, sir. Thank you. I'd now request Dr. Divakant to take it from here. So he'll be giving his talk on OCT, a must-have in your practice, facts and myths.
I wanted some comments from Himanshu actually.
Yes, I just wanted to, in the interest of time, Dr. Lalit Verma, every word said, he actually hit a very fast 6 out of the stadium. Srinivas, in the age of T20, I can tell him that in the stadium like that. What he mentioned are quite a few very interesting things, how to self-innovate, how to self-motivate, and how to do things. Going abroad is must. Seeing a point of view of various people, going to various institutions is absolutely a must. I must tell you that when I went to US for my fellowship, that was the game changer of my life, and I can promise you that. And what Dr. Lalit said is very true. Every person has so much to teach from our national people, international. We may be very nationalistic, but going and learning from people everywhere can change your perspective. You will learn, you'll be able to see a lot more about the world and how they practice. Eventually the same surgery. But I will go back later when we have time, but this is the most important takeaway, that expand your horizons. Don't be stuck in a small area. You have enough time to start your practice. Don't be in a great hurry. The rest of your life, you're going to be doing that. But if you don't learn now, when you start, then you're not going to innovate later. And learning is there regularly at every given point of time for the future. What we did during our undergrad, post-grad days, not one thing are we practicing today. Everything has changed.
Coming to Divakant, what Divakant has achieved at his age, we didn't achieve even 1/10 of that. So because he thought differently. So we'll hear Divakant and then maybe talk again.
I think it is, whatever has happened has been because of guidance from seniors like you. And coming to the topic, and I've spoken about this topic about conferences, as Dr. Srinivas sir was mentioning. And these travel grants and the exposure that you get in these conferences has been so enormous for me. I got to meet so much, and Lalit sir and people like him, I have not known them personally, I have not worked under them, but meeting them through conferences and meetings has been a great mentorship experience for me. So you get to talk to them, interact with them. So that is the one of the biggest takeaways from these meetings. And another thing that for all the youngsters, I would like to say that take your meetings, your conferences, don't attend too many of them, but whichever ones you attend, mark them out for that calendar year and take them really seriously. So during my training period, I tried and attend a lot of international meetings as well, but I separated work and pleasure. So the 4 days of the meeting was very serious for me, and the abstract book and all the sessions that were going on were properly marked, and I tried to attend all of them. And the traveling and the tourism aspect came later. So you should really take those seriously, and you will get a lot of impact and a lot of value to your career professionally from them. Thank you.
Dr. Divakant sir, you can start your talk, share your screen.
So you're on mute.
Yes, I hope I'm audible now. Yeah.
Yes.
Yeah. So thank you, the whole organizing team and IRSI and youthful part of IRSI for giving me this opportunity. I'll be talking very briefly on the retina practice aspect. The topic that was given to me was the difference between the full-time practice and freelance, but I'll try to cover briefly all the aspects of retina practice. And I hope that all the panelists, all the seniors that are present here are from different aspects of practices. So I really hope that we can have some inputs from them, and they can really guide people like me and all the other juniors how to proceed in their careers. So what after fellowship? There are a lot of options for a retina surgeon these days. Of course, a charitable government or a tertiary institute, the big institutes, you can join one of them. You can join a corporate practice, a private or a group practice, and of course, freelancing. So I'll take each of them really briefly so that we can have time more for the discussion on them. I'll talk about just pros and cons of these practices. So a big institute gives you the opportunity of a high volume of patients, and of course, access. Some of these institutes give access to the latest technology that is there in the market these days. This in totality helps you in advancing your career. And a lot of us after the fellowship realize that there are certain lacunas in our training, and probably we are not ready for a full-time practice or an independent practice. So this gives you that opportunity, and you can find some great mentors there who can guide you in your careers. And as Srinivas sir was talking about research and publications, so these institutes give you that opportunity. And of course, if you're passionate about teaching, that also comes in here, and no investment from your side. The negative points being that the salary can be a little on the conservative side. There's a certain hierarchy in the institutes which you need to follow. You are not the boss here. You are seniors whom you report to. So things won't happen always the way you want them to happen. And there are rules and regulations of the hospital that you have to stick to. Coming to the second, that is the corporate practice. A lot of corporates are coming in, and they're opening even in the smaller cities these days. So it's a very good opportunity for young retina surgeons. A big plus is the salary. You start at a very decent salary. You get access to premium patients, and some high quality patients are there, and you get the confidence, as sir was talking about, when you, Lalit sir was saying, when you operate on a very VIP patient, so you have the access here. Most of these hospitals have good infrastructure and equipment that they provide you, and you acquire some soft skills, management skills, and how to, the commercial aspect of things are also comes in there. And again, no investment from your side. The negative aspects being that it is a skill and a revenue-driven model. The standard of skill, the standard of training in India is pretty good compared to other countries, but some of us might not be that well trained and find it really difficult to survive in a corporate setup. And again, during our training, we are not exposed to the revenue aspect of the business aspect of the practice. So that can be a cultural shock kind of thing, where people are talking about money and revenue and the number of surgeries and patients. So that can be a bit difficult for some. There is practically very less or no job security. Most of the corporate practices have a retainership kind of a model where practically you can be chucked out on a day's notice. So that is always there. Being on a retainership model, but still it requires full-time commitment, and most of these hospitals don't allow you to get attached with other hospitals. And a lot of these hospitals have multiple centers. I need to, I'm part of a corporate hospital, I need to look after around 7 to 8 centers. So it might involve a lot of traveling. Coming to private practice, a lot of us want to start this and jump into this. Of course, you are the boss here, you are the brand, people are coming for you. You get to decide how things run here, and might be financially better in the long run. So it's like a startup. If it's successful, you are the boss, you are the winner here. But of course, certain negative, a lot of heavy investment, especially a retina practice will incur a lot of cost, and maintaining these equipment is really costly. It's a 24/7 commitment from your side, at least initially. There are a lot of accreditation and norms that you need to follow these days. And what people are doing these days are they're moving away from the big cities because of the super saturated cities and the high cost of land and all these things. It becomes difficult to set up a practice here. Now, another thing that is coming up is the group practice. A lot of people are going for that. It has basically all the pros of a private practice with lesser liability and all the cons of a private practice. But it's really difficult to find these like-minded people whom you can work with. Last but not the least, of a freelance practice, practically very less investment here as well, and might be the only way in metro cities. So in cities like Mumbai and other cities, people have, this is the only option for them if they want to stick to the city. And you don't need to really worry much about the patient load because the hospital takes care of that. The negative aspect of it being probably you are not the brand here. People might not come for you. You are just the pardewala doctor or the retina surgeon of that hospital, and people don't recognize you that well. Involves a lot of traveling, of course, and since you're traveling and you're always moving, follow-up of the patient is difficult. So if there's a complication the next day, you might not be there to cater to the patient. And of course, again, there is no job security. If this hospital, the hospital you're attached to, wants somebody else, or their children come into practice, then of course you lose the job. So coming to how to find these jobs, as Srinivas sir had talked about VRSI, there are other job portals like Yosi has also a job portal, and AIOS has a very old job portal. They have been putting jobs from a very long time there. So you can access these sites. And the Young Ophthalmology Society of India has a help desk as well, where you can mail us on the official email ID and we can help you in finding these jobs. Thank you so much.
Thank you so much, sir. Thank you so much for what in your experience is the way forward, because you got out of fellowship. Then, of course, we know that, now you're in a corporate hospital. Was there anything in the middle that you did?
No, I felt confident at the end of my training, and I'm probably right. And I joined a corporate hospital straight out of my training. I was pretty comfortable with that, and I'm visiting certain other centers also. So I have this experience of a freelancing model as well. But it is really difficult for me as of now to say what would be the right way to go. I think it's a very individualistic approach and depends a lot on the geographic location as well. But I would really love to have inputs from all the seniors here, because that would really give us an insight.
Dr. Srinivas, sir, your thoughts?
Excellent talk, Diva. I think you have just spilled the beans, and what the freelancer or the person who doesn't have the backup or who doesn't want to join the institution, you have just told that very diligently. I agree with most of the points which Dr. Diva has said it. If you want to do a freelance practice, definitely it's a good job, and it has to be in a bigger cities. Smaller cities, if you are going to do, you should not touch cataracts at all. The moment you touch the cataracts or start doing anything, the referrals immediately stop there. And I have seen, because I go to Goa to operate there, and I see a couple of freelancers coming in and trying to say, sir, would you like to do? Because see, nowadays Vitreoretina has become slightly expensive. Now, if you want the best of the setup, then it goes into either the Constellation or many other, which might be difficult for the initial people to invest. But I'm sure it's just a time. You can start with the Reticare machines or any of these kind of machines, which are equally good, the Indian brand machines. Try to take less complicated cases in the beginning. Once you gain the confidence of the people around, once they start referring you the cases, once they get to know that the referral doctors, okay, he's a good surgeon, I had sent a patient, he has done really good. That is when you jump into doing for complex cases. Immediately, once we go in, one patient can definitely not try to bring a bad name to the doctor, because he's a single-handed and he's not under the shadow of the institution. If you are under the institution shadow, the institution takes the whole blame. But if you are a private practitioner, a freelancer, then definitely it's always better to take up and have a good rapport along with the people who are around. Try to go and meet them. Try to tell, sir, I've started my practice. I would like, even though they like you or they don't like you, just try to go and meet up. Try to gain confidence. Try to take up their confidence, sir. I'm always there. Any help you need, please let me know. The kind of humbleness we people show when we are doing a freelancing, that is where when we win their hearts. And that is when we start getting more and more referral practices. For the institutions, I don't think anything to be said, because most of the things are run by the institution itself. And the rest is left to Lalit sir is smiling. I don't know what point. Yes, sir. Go ahead, sir, please.
No, I am in absolutely opposite of what Srinivas said. Freelancing should be discouraged. I don't, after having so much of this thing, never do freelancing. The reason is you are exploited at least. You see, Himanshu, even though he had retina training, but now he is a great cataract surgeon. Amar, retina trained, he is a great cataract surgeon. Abhay Vasavada, cataract, retina trained. So my thing, after having spent nearly 3 decades, 3.5 decades into retina practice now, freelancing, I would discourage. It's a sheer wastage of time, and it's exploitation by all these big people. So they call you, and you never develop anything of your own at all. You see, if you have the confidence, you see, therefore, I always tell all these people who are budding, do you have the skill set or not? If you have the skill set to deliver, like you can confidently, make the ports, do a vitrectomy, mobilize the retina, settle the retina. If you have this skill set, please do not do freelancing. Freelancing, उससे better तो ये होगा कि you open up a small, even though you may have to take a loan. Then you should, because skill set is important, very, very important. So you see, travel, they will make you travel from here to there, from Chandni Chowk to Karol Bagh to वहाँ, आज वहाँ चले जाओ, वहाँ एक केस है, आज वहाँ एक केस है, वहाँ एक केस है. You keep running around. By the time you realize you're already into mid-40s. You see, by the time you finish your senior NC, you are into early 30s. And 1 decade you may waste. So therefore, that is not my cup of tea for anybody to do freelancing. What I would advise instead is, after you have done a fellowship, because never jump into any kind of practice after doing a post-graduation. Even though you may be Einstein or genius, immediately after MD, you are not prepared for a VR practice. So 3 years of fellowship, or what we call senior NC, is a must. Travel, even at your own cost. Paisa nahi milta hai, koi baat nahi. But aim should be to develop a skill set, and first couple of years spend in a charitable setup or a government setup where high volume, take advantage of the high volume, because high volume will give you confidence. And once you develop confidence, then you can dictate all the Amars and Mahipals and Vasavadas and all these people. If you don't, then they will exploit you reverse. You can record this, no issue.
Dr. Mehta, your thoughts?
What Dr. Lalit said is, either you ride the horse or the horse rides you. That's the story of life. If you want to lay the rules of the game, don't get exploited, no question about it.
Right.
And the world is there to exploit. If you allow yourself to be exploited, there is no reason why somebody will not exploit you. Every possible reason, your body language. And what happens is, when you just finish fellowship, you're still not confident. You don't have enough bloody money to take a car, also have anything. You don't know whether you'll be able to sustain your family. You're still struggling, and you're not even sure whether you'll be able to handle most cases, because as Dr. Lalit says, skill set. When will you cut off the cord and you know that you'll be able to handle the case on your own? That is where he said, consistently have huge volume. Something said very important, go in a high volume practice. So middle of night also, आँख बंद करके, जिसको नहीं करना है, जिसको छुट्टी लेना है, let them enjoy. You do all the complicated cases. If they want to go party, they want to do whatever, you have the pleasure of doing as much work as you can. And we are all finally mechanical people. Surgeons are mechanics. So subset, spinal level, we are going to be operating. The more number of cases that you've done, it is cataract, it is phaco, it is whatever that you saw. And as he said, he hit the nail. Don't let yourself to be exploited. Do maximum number of cases, cut the cord, start your practice, get your confidence. And there is enough place for everybody. Don't get overwhelmed that it is full. There is enough place for everyone. Nobody goes hungry. Get that confidence back in your mind. Whichever way you start, the dots will settle up later in life. But start, push yourself, get on going. That's it.
Dr. Saurabh sir, your thoughts?
Sorry, you have a bench. Yes, Saurabh, after.
I think I agree with what has been said, that especially in a smaller city, what Srinivas said, that you should try not to touch the cataracts, because that is not a very good thing to do. At the same time, I would say case selection is very important, especially in a retina practice. You should go for good prognosis cases initially, especially in a smaller private practice, because that helps build up your practice. and also giving feedback to the referring surgeon. Nowadays, even on WhatsApp, you can just maybe just click a picture of the report or whatever you found, or you've done an OCT, so that gives a lot of confidence to the referring surgeon to send patients to you, because he's updated about what happened to his patient. He's very keen to know what happened to what was the outcome for the patient. So I think all these are very valid points that people have discussed.
Sir, just one point I want to make, Pooja, in 30 seconds. Like, sir, I partially agree with your point about the exploitations being done to the freelancing system. But what here I say is, for the people who doesn't have a backup, who doesn't want to join the institution, they can join the freelancing initially. But I make sure that wherever you do the freelancing, you have to put up a board that the Retina services is provided by this person. You should not become a shadow surgeon. That I always go against it. You should not tell that, okay, I am doing.
But how many of these, people will allow you to do this with shadow?
Yeah, that's what I'm telling, sir. If they allow you to
They
do
will
it,
not. All
then
these
do it.
people
But
don't allow.
never be a, yes, sir, I agree with your point, but never be a shadow surgeon.
Yeah, yeah.
Like telling that they are doing and you are going inside the OT and trying to do that. That never has to be done. That if you want to do it at a board. I always tell them, if you want my practice, put up a board that it is being done by so and so institution, so that let that institution go and cater that. And by that, at least some patients, he'll build some clientele. That's what I was just trying to. But points well taken, sir. In nowadays, in certain situations, especially in big cities, they are being exploited. I agree.
Thank you so
Lalit,
much.
Dr. Lalit, you were saying something. I want to hear that point of view. Something.
No, I think in the initial 5 years of your, after you finish, do not pay any attention to money at all. So don't think that you have to earn. Believe me, that first 5 years of your, after you finish your residency, after you have acquired your skill set, you're confident. So keep doing, whether anybody pays you or not, I don't care. But after you have, settled so many retinas and done so much, of all the surgeries, then you can. You see, because inner confidence has to be here. That comes from within you, that I can do it. And then I think you can dictate by, this is what I want. And if you have, if your father is, or one of your relative has already practiced, then sky is the limit. If not, the issue comes there, whether what Devakant was saying, that a solo practitioner has to have a heavy investment. This does not matter. You see, all of us, in fact, all of the younger people listening, should always begin a small investment if they can. A 2-bedroom house in a commercial area, similar to 1,000 square feet, should be taken, whether you know the job or not, because that will be your ultimate, savior. Suppose you don't get a job, suppose you are cut out, suppose you are whatever. First investment, don't do on your house, do in a small, around 800 to 1,000 square feet area. That should be your first investment in life, because that gives you confidence that कहीं भी कुछ नहीं हुआ तो मैं यहाँ बैठ के कुछ ना कुछ करूँगा. That should be your first investment. And then I think 5-6 years, keep developing your confidence that alone also you can operate without the help of your mentors or trained sisters. Because you see, in RP center, we are all spoiled. Sisters are so well trained that they can, train a VR surgeon also. So you should learn to operate without the help of all these things. And as Srinivas said, even if you may not have constellation, learn on Appasamy or Reticare or this, because that gives you a lot of confidence that any machine anywhere, because it is the man behind the machine more important. All our youngsters, they want to just enter, make port and do cut and come out. It should not. You see, my fellows who come, so first 3 months I will tell them, pehle beta machine ko aap dekho. We keep every part of the machine which you know, which I have forgotten in fact, but where to put this, and then learn to lay out the trolley, then learn to sit on the side piece for 1 month or so. Then I will make you sit on the main oculars.
Thank you, sir. That was an extremely valuable teaching. We will definitely keep these points in mind in the future.
They're just suggestions. You see, all Devakant and all they and even in Rohan, they now are big people. They can easily guide us also. But it's a mutual learning. Believe me, it's a mutual learning depending on a couple of factors: your financial situation, whether your pop is a doctor or not, whether he has a clinic or not. These 3 factors will determine what you will do. Like Rohan is blessed. He can open practice anywhere. He can buy 3 constellations today.
So reminds you of the book Rich Dad Poor Dad.
Yes. Yes.
Yeah, that's what Dr. Lalit Verma is talking about. Invest in your business.
I am being very straight and honest. I do not, mince here and there.
Yes, absolutely brilliant point of view. Rich Dad Poor Dad. I did that. That is the name of a book which most people should learn in investing. That invest in your business. Don't buy a car. Buy a machine. The machine will buy you 10 cars. You don't have to have a Ferrari, but your femto can get you a Ferrari possibly somewhere.
So in Hindi, a lot of our oldies used to tell us, "Dukaan se makaan banta, makaan se dukaan nahi banta." Therefore, I said, please invest in a small space. Small space होना बहुत जरूरी है.
Introducing our next speaker, Dr. Saurabh Luthra. He's the Director of Vitro-Retinal Services at Drishti Eye Institute, Dehradun. He pursued his Vitro-Retinal Fellowship from Shankar Nethralaya and went on to do a research and clinical fellowship from University of California, Irvine in USA. He has been an invited speaker in national and international conferences and wowed us with his skillful surgical videos. Dr. Luthra joins us to give his wisdom on the changing paradigm of retinal surgeries over the years. Over to you, sir.
Thank you, Dr. Anshika, and thank you to the IRSI executive, Dr. Himanshu Mehta, sir, and also the youthful IRSI led by Rohan and Pooja. And so I would like to just start sharing my screen. I'll be speaking on changing paradigm in VR surgery. So can you see my screen now, please?
Yes, sir.
Okay. So I like to start my talk with this picture. And so for all of us who trained long back, maybe about 20 years back, we were very used to doing scleral buckling. And these are the gory pictures which one can, actually see, all the buckles and all the explants which are there. And in fact, I've also assisted implants when I was trained at Shankar Nethralaya. And mind you, that was a very time consuming, very gory, as you can see. Then came the pars plana vitrectomy, and the first pars plana vitrectomy was described by Macamar way back in the 70s. And initially there was a single instrument, and then came the 3-port pars plana vitrectomy by O'Malley. And then came the sutureless vitrectomy system, which was initially introduced by Chen, and then Fuji, who gave the 25-gauge sutureless vitrectomy, and Eckart, who gave the 23-gauge sutureless vitrectomy. So initially there were some issues with the rigidity of these instruments, but the newer 25-gauge plus and 27-gauge plus probes and instruments have a stiffening sleeve, which has overcome this problem. Wound construction was also initially an issue, but then it was found that when we made oblique incisions, then it was better. Surgical time, it did not really, change the surgical time much, because the time you saved in, going in and coming out was actually spent during vitrectomy, because the vitrectomy times are a little more with the MIVS instruments. Some complications can occur like hypotony, but if you do a partial fluid air exchange and if you are very diligent about closing any leaking sclerotomies, then you don't face this issue. Endophthalmitis, recent studies have shown that it is not, MIVS is not associated with higher rates of endophthalmitis. And retinal detachment also is not found to be more common with MIVS, and it is not found to be related to the technique itself. So initial indications for 25-gauge vitrectomy were the straightforward posterior pole cases like an epimacular membrane, macular hole, CSME, VMT. But then came the expanded indications for various kinds of retinal detachments. I won't go into the details. And you can also do a hybrid vitrectomy in which you can combine a 25-gauge and a 20-gauge instrument for, let's say removing a nucleus in a case of nucleus drop. So MIVS is here to stay, and there are various, gauges which are available like 25 gauge, 23 gauge, 27 gauge. And this is the most popular system, the Constellation Vision system from Alcon. I don't have any financial interests. So what are the advantages of MIVS? So there is more patient satisfaction. It is more comfortable. The eye looks normal, and there's quicker visual recovery, less astigmatism and less inflammation, less operative time, and it is ideal for patients with filtering procedures. Various illumination devices have been developed by Eckart, like the Twin Light, the Oshima, who developed the 27 gauge and the 29 gauge mercury vapor illuminations. Chandelier systems are also there, which enable us to do bimanual vitrectomy. So there are various indications for bimanual vitrectomy. And now we have the 27 gauge, which is the most recent one and which is becoming popular now. And you have the valved entry system. So this enables us to have a closed system so that there is very little flutter of the retina, and you are able to do a safer job inside the eye. Then you also have a vent, the purpose of which is for normalizing the pressure. And this is the stiffening sleeve, which I was talking about, which enables us to do surgery with these finer instruments without tool flex. And then we have this finesse, which is my preferred instrument for scraping. I used to use the Thanos diamond dusted scraper earlier, but this finesse loop is really very nice. So the Alcon Ultravit has, gone on to 10,000 cuts per minute. So way back we were, at very less cuts per minute, but now we have the valved 10,000 cuts per minute bevel tip. So this is the technology which actually is a game changer. So as you can see in this cross section, that this Alcon has a high-speed probe which has a dual pneumatic drive. So both the to and fro motion of the cutter probe is active, not passive. And so these are the advantages, that you have fewer iatrogenic breaks and you can have more efficient vitreous removal. And I won't go into details, but you can do diabetic surgery very nicely with these bevel probes. So the latest, the latest development is Ingenuity, which is, the 3D surgery, and in which, you have a 3D display screen, and it's a heads-up surgery without any oculars, and the surgeon and the assistant, and it is also very useful for training because everyone in the operating room can wear these 3D glasses and can have a three-dimensional aspect of the surgery being done. So initially we were used to a picture which was like this, and then with high definition it became like this. With Ingenuity, this is the kind of change in perspective that you might have. So if you see here that you are focused on this arch here, but with Ingenuity you can focus at the entire field. And it has been integrated very nicely into the Constellation system. And it also is definitely ergonomically much better, with 85% of retina surgeons who complained of neck and back pain, it's much better for them. So this is a short video of the Ingenuity. So you can see that the surgeon and the assistant, and along with the other trainees, are wearing these 3D glasses and are observing the surgery being done on the screen in 3D. So it does, totally change the perspective of surgery for the surgeon. I'll just go over to the next slide. So another game changer, which is supposed to be a game changer, is intra-op OCT, which is actually integrated OCT into the microscope from Zeiss. That is one of the machines which has it. It's the Rescan 700. And it is very useful for simultaneously.
I didn't get that. Could you try again?
I'm sorry. So IOCT is very useful for integration with the microscope, and you can visualize, the epiretinal membranes, simultaneously on the OCT. And it is useful for monitoring vitreous traction during macular surgery. Also to see where the membrane edge is. So while doing epimacular membrane peeling, you can look for the edge of the membrane using the intra-op OCT. So some new developments, as Dr. Lalit Verma sir was also telling, with the bionic eye, which is from second sight. It's a retinal prosthesis which bypasses the damaged photoreceptors with a mini video camera housed inside a pair of glasses. The camera sends signals to an implanted chip near the retina, which stimulates retinal cells and produces visual light patterns. So this system is supposed to work only for people with conditions like retinitis pigmentosa, because the disease only damages the eye's photoreceptors and leaves the retinal cells intact. For these patients, the retinal prosthesis is effective enough that they can recognize objects, see people, and follow movement. So it just gives gross vision. So I'll just go to a few of my cases. So this is a lady with the pre-op vision of 3/60, and you can see a full thickness macular hole in the right eye. And this is a 27 gauge macular hole surgery, which I've done for this patient. And I'll be doing the inverse ILM flap. So just initiating the PVD, then IVTA. And then just peeling the ILM in flower petal appearance, and just getting all these flaps to oppose onto the macular hole. So this just ensures that, this technique is mostly used for large macular holes. And then doing a careful air fluid exchange with C3F8 gas tamponade. So this patient got a vision of 6/60 post-op, and you can see that the hole is nicely closed. So another condition where MIVS is very useful is the 25 gauge, optic nerve head pit with maculopathy. Had best corrected vision of 6/18 in the right eye with optic pit maculopathy and foveal thinning due to chronic neurosensory detachment and retinoschisis. She underwent IVTA assisted 25 gauge vitrectomy. DBG dye assisted juxtapapillary ILM peeling with apposition of peeled ILM over optic disc pit as opposed to a macular hole. The apposed ILM in optic disc pit has a 30-year-old lady and retinoschisis. She underwent IVTA assisted 25 gauge vitrectomy. DBG dye assisted juxtapapillary ILM peeling with apposition of peeled ILM over optic disc pit as opposed to a macular hole. The apposed ILM in optic disc pit has a tendency to remain plugged inside the pit due to negative suction pit, air fluid exchange, and C3F8 gas tamponade. At final follow-up at 18 months, best corrected vision had improved to 6/9 with complete resolution of neurosensory detachment. This is another case of posterior dislocated multifocal IOL, which was managed with 25 gauge MIVS. And you can see that, that is the IOL, which the vitrectomy is done initially. And once the IOL is free, I'll be picking it up with a forceps. And these are the 25 gauge trocar cannula system, and with the handshake maneuver, I'm transferring it to the other hand and then making an entry into the anterior chamber. And without actually explanting the IOL, I was able to just relocate it into the sulcus. And thankfully, there was good centration, because again, with multifocal IOL, you want good centration. This is a case of live intravitreal cirrhosis. Understood live intravitreal cirrhosis with retinal detachment with severe PVR. Ultrasound B. scan left eye showed an oval hyperreflective cyst with hyperreflective scolex and incomplete PVD. So I think there's some issue with the video under topical and oral. But basically, I did an encerclage band for this patient. Conjunctival peritomy was done. Stacked scleral tunnels made in 4 quadrants and passed stored with hitch knot in the supratemporal quadrant. 25 gauge MIVS surgery was done. We can see the remarkable undulatory movements of the cyst as which vitrectomy is done. So you can see these sieve-like holes which the the scolex had created, and finally the cyst was eaten in total inside the eye. Scolex of the cystic circuit. Finally, I'm sorry about the video stopping. So you can see the scolex here. You can see the scolex once the cyst is eaten inside the eye. Out once the cyst is eaten with the cutter. Extensive endolaser was required. Silicon oil was injected. Silicon oil removal was done to remove extensive epiretinal membranes over the posterior pole and internal limiting membrane over the macula. At final follow-up at 1 year, best corrected vision was 624 parts. PCL was in situ with central PC opening. Fundus showed attached retina with extensive peripheral scarring in the area of laser sparing the macula. OCT showed flat retina with resolving minimal macular edema. And this is my last video of a giant retinal tear with retinal detachment. Again, managed with 23 gauge. So with that, I just finished my videos. I'm not sure if I have a couple of minutes or a minute more, but I just had pulled out these few studies because Rohan wanted me to talk about the visual outcome per se and the changing paradigm. So, this is a recent study which just said that, the PRO study report number 9, which says that retinal detachment with inferior breaks has a higher single surgery success rate if treated with PPV and scleral buckle combined. So still there is a role for scleral buckle. So this is a study of long-term outcomes of 27 gauge vitrectomy and which showed good results with 27 gauge vitrectomy for most of the posterior segment conditions. And all these MIVS 25 and 27 gauge were found to be useful for conditions like epiretinal membrane and full thickness macular hole. And earlier we had these studies about 15 years back on ROP, And now we have studies of MIVS in ROP surgery with good results, showing good results. So MIVS is being used for most of the conditions now. These are a few studies on heads-up 3D viewing. This one is from RP Center, and another one from the Arvind Eye Institute, which showed that anatomical and functional outcomes of surgery were favorable with this heads-up surgery compared to the conventional microscope surgery. And also it gave rise to better ergonomics. And bimanual vitrectomy with MIVS was good for diabetic retinopathy. This is a study from Strophy Center. And also we have studies, of scleral, without doing scleral depression, the wide angle viewing system are very helpful, and we don't even have to do much of scleral depression nowadays. So with that, I come to the end of my talk, and thank you so much.
Thank you so much, Dr. Luthra, for taking us through the various generations of retinal surgeries from where it began to where we are now. It gives me immense pleasure to introduce Dr. Neil Bressler, our next panelist, who absolutely needs no introduction. He is the man behind all the diabetic retinopathy clinical research network protocols that are followed across the world. He's on the chair of the trials related to diabetes like the DRCR.net, National Eye Institute, and multiple FDA trials. Dr. Bressler is currently the editor-in-chief of JAMA Ophthalmology. His expertise solely lies in diabetic retinopathy and macular degeneration. I've had the absolute pleasure of doing my retina fellowship under him. That 1 year with him was my absolute favorite, as I got to learn so much from him. We have the honor to have Dr. Neil Bressler speak on the clinical trials of managing diabetic retinopathy. Welcome, sir. Thank you for being a part of our show.
Well, thank you, Pooja. Dr. Pooja has been my wonderful connection with the up-and-coming ophthalmologists in India. It's just a pleasure. And it's a pleasure to always interact with all my colleagues there. I wish you all well. The pandemic that has gone on is always our first priority. And we feel for everyone that has had challenges from this. We understand that it's not over. We have a lot of work to do. But at the same time, we still have to take care of people with diabetes that affects their eyes. And we're still working on ways of trying to improve the care. Since I've been there, we've had a lot of new studies come out or analyses of other studies, and I thought I'd spend about 30 minutes or so talking about what we've learned and how we approach diabetic retinopathy, and then maybe 15 minutes for some questions along the way. So I'm going to share my screen, and I'll go through where we are with all of this. And just let me know if you can indeed see the slides there. Yes, Pooja?
Yes, sir, we can.
Okay, good. There might be a slight delay as I go forward. It has to go just a little across a few oceans here to get to you all. These are my financial disclosures. We have grants from industry to the university to help support the research efforts that we're doing. I wanted to present how the data influence our current management of diabetic macular edema. And first and foremost to say, we actually base our decision on the visual acuity when the person walks in. We don't base it on what their OCT looks like. We don't base it on their hemoglobin A1C. We don't base it on their diabetic retinopathy severity scale. We don't base it on their high blood pressure. We don't base it on if they're type 1 or type 2. We keep it simple. We base the management on their visual acuity. Now, this first started about 6 years ago. In 2015, the DRCR network looked at 3 different agents for treating diabetic macular edema. And they reported that the decision-making is different if the vision were 2032 to 2040, or if the vision were 2050 or worse. When the vision was 2032 to 2040, treatment led to improvement. So you still treated people, even though the vision was relatively good. On average, there was a 7 or 8 letter gain. That's the average. Behind that average, some people had no gain. They were all 2032 to 2040 to begin with. So if they had no gain, they still did pretty well. But some people gained 2 lines, maybe to 2020, maybe to 2016. But the average was that everyone gained about, on average, 1.5 lines for the whole group. But I'll show you how this is clinically relevant in some future slides. It didn't matter, though, which agent you used, whether you used aflibercept, bevacizumab, or ranibizumab. We couldn't find on average a difference between all 3, so you could choose either one that you have access to. We also learned for the half of the cohort that were 2050 or worse, it did make a difference which agent you would take out of the refrigerator. Doesn't mean you have access to all 3. If you only had access to bevacizumab in blue, that works very well. That has a substantial gain on average. It's just not as good if you were able to take aflibercept out of the refrigerator. This gave, on average, gains that were definitively different from the ranibizumab group in yellow or the bevacizumab group in blue at 1 year. Now, at 2 years, it was still definitively better than bevacizumab, but not necessarily ranibizumab. And we'll come back to that disconnect at 2 years versus the results at 1 year. But I want to start with this table that was in the 2-year outcome. These are 2-year outcomes for the cohort that started 2032 to 2040. So they started with good vision. It was about half of the group. You can see it's about 300 people given either aflibercept, bevacizumab, ranibizumab. And I want to look at how many people, what was the percentage that ended up 20/25 or better? That's really good vision. And the percentage was about 70%. So I didn't tell you what the regimen was. I just said that in this group that started 2032 to 2040, following the regimen that I'll describe, about 70% were 20/25 or better. Now, if you walked in 2050 or worse, you still have improvement, but now only about 45% are 20/25 or better. So this told us not only does the baseline vision determine whether we have to consider different anti-VEGF agents, but the baseline vision tells you how many people will end up 20/25 or better. If you can get a monitoring system where you catch the person just when they're 2032 to 2040, 70% end up 20/25 or better. If your system doesn't pick them up until they're 2050 or worse, it's still better to treat with anti-VEGF than laser, but only 45% end up 20/25 or better, a big difference. You'd rather catch them, if you can, at 2032 to 2040. Now let's go to this concept. We said when they're 2050 or worse, aflibercept was superior to bevacizumab or ranibizumab at 1 year, but for ranibizumab, not at 2 years. Why would we still start with aflibercept if they're 2050 or worse? Why not ranibizumab? Because over 2 years, the time spent with improved vision, the area under the curve with improved vision is greater with aflibercept than ranibizumab, okay? So let's go into what we see for the area under the curve. What we see here is for the area under the curve in orange, it's superior to use aflibercept than either ranibizumab, the area under the curve in yellow, or bevacizumab, the area under the curve in blue. And that's over 2 years. And that's because when you start at 2050 or worse with aflibercept, you don't close your eyes and then open them at 2 years. Or you don't start with ranibizumab and close your eyes and open them at 2 years and the vision's the same. Yes, it is. But your eyes are open at 1 month, at 2 months, at 6 months, at 1 year, and over that first year. There's more time spent with improved vision when looking at the average vision of the 3 groups. Now that's just the average vision. That's for the groups. But we then typically look at clinically relevant outcomes that go behind that average. For example, we look at the percentage of people that end up 15 or more letters better. And we choose that because there's 5 letters on each line of these charts, and every 3 lines or every 15 letters, the letters are half the size. Now, what we do is when we have people that are 3 or more lines better, they can read better. They have much better vision. And so that's a clinically relevant outcome behind the average changes. And what we can see here is that when the baseline visual acuity is 20/50 or worse, you're more likely to have 3 or more line gain at 1 year if you had started with aflibercept, then ranibizumab or bevacizumab. 40% with bevacizumab gain 3 or more lines. That's great, but not 67%. And so you don't know how the individual is going to do. We cannot predict beyond the baseline visual acuity what affects the outcome. Now, this looks at 2 years. There is no difference. That doesn't mean you shouldn't start with aflibercept if you have access to it, because over 2 years, these data tell us you're going to spend more time, 3 or more lines better over 2 years if you start with aflibercept when your vision is 20/50 or worse. Again, I haven't gotten into what the regimen was to get these outcomes, so I want to go over that now. The objective was to try to maximize visual acuity, but maybe minimize the number of injections or visits. So we started with 6 monthly injections. We kept it simple. There was one exception. If you were 20/20 or better and the OCT appeared normal for 2 consecutive injections, you could withhold injections in the first 6 months. But 95% of the people in the first 6 months are not 20/20 or better and have a normal OCT for 2 consecutive injections. So most of the time, you want to educate the patient to say, I want you to end up 20/25 or better. We're going to start with 6 monthly injections. Thereafter, not forever monthly, the first 6 months, 6 monthly injections. Thereafter, we're only going to treat that person if they're still improving. Improvement trumps everything. If they're not still improving, then we're going to withhold treatment. If they're stable, even if they're thickened, if they're stable beyond 6 months, we don't have evidence that it's worth continuing to treat these people. The lines level out and they don't decline when we withhold treatment. And when you compare this to, for example, industry-sponsored trials by Vivid and Vista, when they're given monthly treatments, there isn't greater improvement beyond what's seen with this as-needed regimen. This is not a treat and extend regimen. This is monthly monitoring in the first year and treat as needed beyond 6 months, only if they're improving or if they're worsening. And if you withhold treatment, then you would resume treatment if they start to worsen. And in the second year, if they're stable, we would double the follow-up, not to monthly, but to every 2 months. And if they're still stable and we're not treating, we would double the follow-up to 4 months until the edema comes back or the vision worsens, and then we resume treatment. Now, improvement or worsening is defined for vision and OCT. For vision, it's defined as changing 1 or more lines, 5 or more letters on the chart. And for thickening, it's described based on the central subfield thickness, not the cystoid abnormalities, not the subretinal fluid. You can look at those to see if the internal limiting membrane to the pigment epithelium was identified correctly by the automated algorithms in the machine. But if they find it, we don't look at the morphology, we look at the number. And if the number changes by 10% or more, that's probably a real change. So going from 400 to 360 is at least a 10% change. Or going from 350 up to 385 is probably a real change. Now, why do we start with 6 monthly doses? We do that because after the first dose, about 30% of the people no longer have thickening beyond 300 microns. 70% are still thickened beyond 300 microns, but 30% are not. And even in that 30% that are no longer thickened beyond 300 microns, they might still decrease. But with 2 and 3 injections, the percentage beyond 300 microns begins to go down. But we don't stop there because with 4, 5, and 6, the percentage beyond 300 microns continues to go down. So with anti-VEGF, we see continued improvement anatomically, not after 3 injections. That's what many people say, oh, I'll start with 3. but there's no scientific evidence that you should do anything but start with 6. There's one exception, as I said, but it applies to very few people. So typically, start with 6 injections, but not just because of the OCT. There isn't a good correlation of the OCT with visual acuity. If you look here, you can see that with the aflibercept, the vision improves on average for the group to about 10 letters, but with 3 more injections, it's up to a 13-letter gain. That's the average for the group, not just one individual, but the average for the group. That's a real change. Now, we don't look at the OCT to determine if it tells us how good the person is doing. The OCT only tells us, do we have to resume treatment? So it guides our management, but it does not determine if we're going to treat people. Or I'm sorry, it does not determine if the person is doing well. So what we see here is when we looked at the Vivid and Vista data, and these are some data that Dr. Susan Bressler presented at the Macula Society, when she concentrated just on the people that were given aflibercept either every 4 weeks or were given 5 initial doses and then every other month. So they're given fixed interval dosing. We learned that the OCT has very little to do with the visual acuity outcome. It has everything to do with should you treat. It's very important, but it doesn't tell you is the person doing well. So we looked at how the change in OCT correlated with the change in visual acuity, either early on at 12 weeks, at 52 weeks, or at 100 weeks. And what this shows us here is everybody above that yellow line, those are the people who improved vision. And everybody to the left of the vertical line, those are the people whose OCT central subfield thickness got thinner. And as you might expect, from baseline to 2 years, we see that most people are in the upper left. Most of the people have gotten thinner and their vision improved, but there isn't a one-to-one correlation. It's not a good correlation. This is what we call, this is like shotgun. It looks like pellets are all over the place on that curve. If you said, for people who decreased by 250 microns, for each individual, some of them lost vision. They're below that line. Some of them gained 5 letters. Some of them gained 10 letters. Some of them gained 25 letters. For each person that perhaps had a change in vision of 20 letters from baseline, some of them decreased by 600 microns. Some of them decreased by 500 microns. Some of them only decreased by 100 microns. Some of them even got thicker. So there isn't a good correlation. There's a correlation, but not a good correlation. The R squared of 9% on this plot tells us that for all the people that you have change in vision, the change in OCT accounts for only about 9% of why their vision changed. 91% of that change in vision is determined by other factors independent of the change in OCT. So the change in OCT does not predict those sort of changes. And we can see that this is also true if we look not only at 100 weeks, but at 52 weeks or at 12 weeks. For each 100 micron decrease, there is an improvement in vision, but it's only 1.2 letters. So that it doesn't predict what's going to happen to the vision. Some people improve 10 letters. Some people lose 5 letters. The average is 1.2 letters. But using this regimen, by treating every month for the first 6 months and then withholding treatment and only treat if it's worsening thereafter on OCT or visual acuity and withhold if it's stable, that does decrease the number of injections. This looks at protocol I from the network, where the vision remains stable through, if you look at the x-axis, 5 years. And there were a median of 6 injections in the first 6 months, but then a median of 3 in the second 6 months, a median of 3 in the second year, 2 in the third year, a median of 1 in the fourth year, and 0 in the fifth. So even though the median number of injections goes down, the average vision remains elevated. Now, these people were monitored at least every 4 months. So everyone was monitored. If they improve, resume treatment. If they worsen, resume treatment. And if they're stable, withhold treatment. And that led to decreased number of injections without a decline in the vision. If you did this in neovascular macular degeneration, you would be more likely to lose vision. Now let's look at what we learned in Protocol T when patients were followed through 2 years, but then they were left to the doctor to decide how to follow them. They weren't systematically followed like in that previous protocol I just showed you, in protocol I, they weren't systematically followed through 5 years. Not everybody could participate in the protocol T extension study where we brought them back once at 5 years, but some of them did, so it gave us some information. We can see that about 70% got at least one treatment, but there was 30% that got no injections, and there was great variability of how many injections they got between years 3 and 5. Some got 2 injections, some got 4, some got 10. The median number was 4. Now, if you look at what I just showed you, the median number of injections out to 5 years in protocol I, that was only 3. So it's the similar number of injections. But if we look here, what we can see is that there was a gain out to 2 years, but then a decline between years 2 and 5. So these people were not systematically followed. What we can see here is even if we break it up by anti-VEGF agent, what we can see is that unfortunately, we still have a decline going on with these people, regardless of the agent, of aflibercept, bevacizumab, or ranibizumab. And even if we break it up into the cohort that was 2032 to 2040, or the cohort that was 2050 or worse, that's what we saw. Now I'm going to take a 1-minute break here, and I'm just going to come on. I just want to bring these other slides on, but just hang on for 1 minute. I'll be right there to continue. And then okay, let me continue if that's okay.
Absolutely.
All right, here we go. So that was how the baseline visual acuity when it's 2032 to 2040 or 2050 or worse influences how we're going to treat it. Doesn't matter which agent you use, 2030 to 2040, it does matter 2050 or worse. And now let's look at what if you're able to monitor people just as they develop edema and treat them or observe them when they're 2025 or better. This was published just a year ago. And this was protocol V from the network that said, what do you do about edema? It involves the center, so it's not a lot, but they're 2025 or better. Should we just extrapolate from those previous trials and say it works for 2032 or worse? Let's use it for 2025 or better. Should we just start with laser and only add anti-VEGF if the vision starts to drop? Or should we observe and only add anti-VEGF if the vision begins to drop? That was the question, to see if one of these was superior to the other. Let me talk about how it was done if you were observed or you applied laser and only added anti-VEGF if they drop, because many people now consider that as a viable option. So people were 2025 or better. They had center-involved edema, and if you just observed them or you added laser, we would see them back in 2 months. Either way, observed or laser, see them back in 2 months because their vision's good. And we ask ourselves first, did the vision drop? A drop in vision is 10 or more letters, 2 or more lines at one visit, or 1 to 2 lines, 5 to 9 letters at 2 consecutive visits that are at least a month apart. And if the vision dropped, if they met those criteria, we start anti-VEGF. And in this case, we started it with aflibercept. So you could observe them and they come in 2 months later. If the vision drops, as we define here, start anti-VEGF. But if the vision doesn't drop, we don't start anti-VEGF, but we look at the OCT. And if the OCT got worse, we don't treat. The OCT got worse because the vision didn't get worse. If the OCT got worse, we just decrease the follow-up to as little as a month's time. But if the OCT is the same and the vision is the same, we just follow them up at 4 months. And we keep going every 4 months until the vision drops, we start aflibercept, or until the OCT worsens without the vision dropping, we don't start aflibercept. In that case, we just decrease the follow-up, maybe from 4 months to 2 months. But until the vision drops, we don't treat. And what we learned is that one strategy is not superior to the other. You could just start with aflibercept, And the primary outcome since they started 2025 or better was just a little worsening, 5 or more letter worse. Because if you're 2025, we don't want you to go to 2032. Or if you're 2016, we don't want you to drop to 2020. But most of the vision that dropped was just 5 letters. So that we can see here that that happened to the same percentage that started with aflibercept, or that got laser and started aflibercept if the vision dropped, or got observation and started aflibercept if the vision dropped. Not one strategy is superior to the other. And as I said, most of this was 5 to 9 letter loss, because only 10%, 7 to 9% really lost 10 or more letters, and less than 5% lost 15 or more letters. And usually that might be going from like 2012 to 2025. If we look at the percentage that were 20/20 or better at 2 years, this was a predefined outcome. We can see that it was slightly better for aflibercept than for laser or observation, but that was the only outcome that had aflibercept to start with being superior. The rescue treatments with aflibercept still had the same percentage, about 85%, that ended up 20/25 or better. And now let's come back to the whole theme of the discussion here. Why do we consider trying to identify people when they first develop edema? Because if you can follow them while they're 20/25 or better and only start treatment if they worsen, you have 85% that end up 20/25 or better. Remember, I showed you if you're 20/50 or worse, 45% end up 20/25 or better. That's good, not as good as 85%. And if you get them at 2032 to 2040 and you start treatment right away, 75% are 20/25 or better. That's good, but it's not 85%. So the strategy should be find people with diabetes, begin to monitor them annually with an OCT to find when they first develop edema, and don't treat them, but follow that edema until the vision begins to drop and treat them as soon as it begins to drop. Or if they walk in at 2032 or worse, you'd have to treat them then. The median number of injections when you do that, and they're 2032 or worse, is 14, 9 in the first year, 5 in the second year. But the median number of injections, if you catch them when they're 20/25 or better and just use it to rescue, it's 8 injections over 2 years. So you use less resources to treat these people. Or even if you just start with aflibercept when they're 20/25 or better, it's 8 injections, not 14 for the median over 2 years. And here you can see that only 35% of the eyes assigned to observation actually worsened. And so 65% never had their vision worsen, even though they had central subfield thickness that was edema. So that tells us we can watch them. And finally, I want to end with some information that was just published last month, and that is managing people that walk in with vitreous hemorrhage that's not clearing, where we typically would manage them with vitrectomy. That was the standard management, and protocol AB asked the question, well, what if you started managing them with just anti-VEGF, waiting to see if it clears, and if it doesn't clear, then go in with vitrectomy. Or if you see on ultrasound traction detachment involving the fovea, then go in with vitrectomy. So none of these people had traction detachment to start, but they had non-clearing vitreous hemorrhage. They might have traction detachment in an extramacular location, but not threatening or involving the fovea. So it could be something like this on the right, where there's vitreous hemorrhage there, or something like this on the left, where there's some traction detachment nasal to the optic nerve. And do you have to always go in with vitrectomy, or could you start with anti-VEGF? And what we learned in looking at this is that you could consider either as alternative therapies. So the design was they had to need intervention, but you either go in with vitrectomy and put in PRP at the time of vitrectomy, or you start with aflibercept only. And the outcome would be, what's the area under the curve at 24 weeks? We know the vitrectomy eyes might improve right away, but over 24 weeks and then over 2 years, what's the outcome going to be? And so we had good follow-up to 24 weeks and good follow-up to 2 years. And you can see here that most of the people, the vitreous hemorrhage was there for less than a month, but some of them had it for longer. And you can see here the vision started bad, 2200 to 2250. And what you can see here is that in the aflibercept group, about 30% might end up with vitrectomy, but not necessarily in the first 6 months. It might happen between 6 months and 1 year, or between 1 year and 2 years. But about 30% would indeed eventually need vitrectomy. But that means 2/3 never needed vitrectomy, so that they may not have to go to a center where the vitrectomy is available. What you can see here is that about 1/3 of the vitrectomy group needed aflibercept for some edema at some point. So both groups would need the alternative therapy at some point over 2 years in about 1/3 of them. Oh, and I just wanted to say about 9 injections were given in the group that started with aflibercept to get the outcomes that we saw. Now, what we saw was for the visual acuity at 6 months, it was no different between the groups. It was a little better in the first 4 weeks for the vitrectomy group, but only at that time point. At 12 weeks and at 24 weeks, the lines are nearly on top of each other. So there's a difference, a minimal difference that is driven by what happens at 4 weeks. Between 6 months and 2 years, still no difference. They all end up the same. So you could start with vitrectomy and that person's clear at 4 weeks, but their vision's no different than if you just started with aflibercept, where 1/3 of them would need vitrectomy eventually, but 2/3 don't. So if it's just their first eye and the other eye is good, maybe they can wait the 4 weeks and then the lines will be on top of each other, depending on which strategy you took. If the other eye isn't good, maybe you want to go in right away so they don't trip down the stairs by not having vitrectomy. So there is a difference in the vision at 4 weeks in terms of who's 20/32 or better, maybe a little difference who's 2200 or worse. But by the time we're out to 6 months, no difference for good vision or 2200 or worse. And by the time we're out to 2 years, no difference for good vision, maybe a little worse for the vitrectomy group at 2 years that had prompt vitrectomy. Only 1/3 of the aflibercept group got vitrectomy. In terms of following these people, you still have to follow them. You can't do the vitrectomy and send them home, because about 25% of them will still get edema with vision loss in the center that needs treatment, whether they get vitrectomy to start with or they get aflibercept to start with. And there are very few ocular adverse events that we see here, and they're similar in both groups, except this traction retinal detachment, where we see it more often with the aflibercept group, but that's not new traction detachment. That might be uncovered. As the vitreous hemorrhage clears, you see the traction detachment along the arcades, perhaps, not involving the fovea. And you can see that that difference didn't lead to worse vision in the vitrectomy versus the aflibercept group. In fact, the aflibercept group had better chance of avoiding 2200 or worse at 2 years. And so we learned that if you have vitreous hemorrhage that's not clearing, you could go in with vitrectomy or you could go in with aflibercept, that these are each good alternatives. If it's their first eye, you might have the luxury to wait 4 weeks, and then there's no difference thereafter. If it's the second eye, maybe you want to go in right away before they lose vision. You get quicker improvement in vision in the eyes assigned to vitrectomy. But from 24 weeks through 2 years, no difference. So if you can wait just a short period of time, you might want to start with aflibercept. Still, if you start with aflibercept, 1/3 will need vitrectomy. So this is what we've learned. We want to base our management of DME based on initial visual acuity. If it's 20/32 or worse, consider managing them with anti-VEGF. If it's 20/32 to 20/40, you'll have a median of 14 injections over 2 years, and just choose whatever anti-VEGF agent you have access to, depending on the individual patient's circumstances. Maybe they're about to need cataract surgery. You might want to get rid of the edema faster. That would happen with aflibercept over bevacizumab. Maybe not, and then bevacizumab's just fine. If they're 20/50 or worse, they will get clinically relevant, definitive, greater chance of ending up with better vision if we start with aflibercept. When it's 20/25 or better, there's a median of only 8 injections, not 14, and you can observe. Or you could start with aflibercept, or you could start with laser. And that's what we've learned, and I look forward to answering some questions maybe for 10 minutes here. And what a pleasure to join all of you and share with what we've learned about treating diabetic macular edema and a little new stuff on vitreous hemorrhage as well. Thank you very much.
So thank you, Dr. Bressler. That was a very interesting talk. And I had a couple of quick questions for you. One is that in cases in which you used, in cases of vitreous hemorrhage in which you used aflibercept, do you attribute any of those, fall in vision to, the crunch phenomenon? Did you see the crunch phenomenon in any of those cases? And my other question is that.
Let me answer that first, because I'll forget. Well, we didn't. So that crunch phenomenon probably is with eyes that already have traction detachment involving the fovea, perhaps in ROP, for example. And so if you're going to put in anti-VEGF right before you do a vitrectomy, it should be in eyes that don't have traction detachment involving the fovea. Or if you do put it in, you want to go in with that vitrectomy within the next day or so. So we don't see a crunch phenomenon in eyes with extramacular traction detachment, in eyes with vitreous hemorrhage, in eyes with proliferative retinopathy and no vitreous hemorrhage. We don't see it. It happens in eyes where there's traction detachment already involving the fovea if you wait a week or two or you wait too long before doing the surgery.
Right. So my second question to you is that in cases in which you use, so akin to the fluid study for AMD, do you think that, like for a country like India, in which patients have a monetary issue, so can we tolerate some fluid and can we reduce the number of injections from 6 to, let's say, lesser number of injections, like akin to the fluid study for AMD?
Yeah, not in the first. Not in the first 6 months, because you might save on some injections in the first 6 months, but you might end up doing more injections for the rest of the person's life. Remember, we showed a median of 14 injections over 2 years if you use that approach, but people end up with excellent vision. We don't know if they would end up with excellent vision if we start withholding in the first 6 months. You could try it, but we just don't know. We also know that if you can, with limited resources, if you can concentrate on catching the eyes just when they develop edema, if you catch them when they're 20/25, not only can you tolerate fluid, you can tolerate thickening, because I showed you that for 2/3 of them that were in the observation group, they all had thickening, but their vision did not decline where you had to intervene. So you want to catch those. And if you do have to intervene, it was a median of 8 injections over 2 years, not 14. This is great when you have a lot of resources or limited resources. So I wouldn't start trying new regimens because we just don't know if they're going to work. Obviously, if you don't have anti-VEGF, laser is a very good treatment. But if you have anti-VEGF, this is how I would use it. And if you don't have aflibercept or ranibizumab and you have access to repackaging bevacizumab, this is how I would use it.
Did you see any drying or atrophy with so many number of injections? Do you ever see drying or some atrophy because of the use of anti-VEGF?
While we do see it, we don't think it's related to the injections, because we have people who got, as I said, not just an average of 14 injections, but an average of maybe 28 injections over 4 years. And if you catch them early, they're still 20/25 or better. So in the few eyes that did not have good vision, it would be either because a macular hole developed, as can happen in anybody, or a central vein occlusion, both in the control group and in the treatment groups, but not due to atrophy. So we don't see atrophy developing in DME following anti-VEGF. We do see atrophy developing in DME, but not at an increased rate compared to a control group. In macular degeneration, we do see atrophy developing, but that's part of the natural history, not necessarily the anti-VEGF, but the natural history of having drusen or having choroidal neovascularization and scarring. The natural history is for the pigment epithelium in many of those to atrophy.
Thank you.
Dr. Bressler, thank you very much for being here and sparing your valuable time. It's been a long time since we met.
Great to see you again.
Very sweet of you to, without any hesitation, to participate in a conference like this right across continents. So sweet of you. And let me tell you, friends, he's a wonderful human being, a great family man. I just wanted to say a few things about him on a personal level. Always smiling, always there for his fellows, and otherwise, he sets the standards for diabetic retinopathy norms in the world. And when he says, this is it, that's how it is, and so wonderful. And he does that with a very smiling face. And he's always got his fundamentals so clear. This is it, not this. And he's absolutely clear in what he says. There are dichotomy in what he says, and that's the best part about him. So nice of you to be here with us, Dr. Neil, and sparing your valuable time early morning out there with the busy OPD. How is the OPD nowadays with the corona scenario? I mean, do you schedule your appointments?
Yeah, so what we did was, before any vaccinations were available, we divided what we had. We had 4 physicians on one floor, and we broke that into 2. And we started them earlier, and we ended them later. And so the 2 physicians took over a broader area so that there were no waiting rooms. So people just walked right in. If they had to go to get imaging, they walked right over to imaging and then back into the room. Anything that we could do to avoid having them interact with more people. Because you have to treat most things, retinal detachments can't wait, endophthalmitis can't wait. We really, ended up at about 85% of our normal volume. We don't see a lot of like just drusen follow-up or epi-brain follow-up. That's a lot of our comprehensive ophthalmologists, and their volume went way down because things were just held off as you saw. But by and large, that's what we did. Our staff were quite concerned, and we tried to be as empathetic as we could for them because they were very worried. They weren't really in school. They were trying to learn from home, but who's home to be with them? So there was a lot of potential stress for them, but they all did their best. And we were able to get about over 85% of the staff vaccinated right away within about 2 months. And so that helps because their level of stress goes down. The ones who didn't refuse, they might be pregnant and they were waiting, or they might have some immunocompromise that says, well, let's wait first before you do it. So we had a very good uptake on that. And now we've been able to get about 85% of the people over age 70 to get vaccinated. And now we brought that down now to 70 and 60. And it's just probably another 2 or 3 months that will open it up to everyone. And the question will be, will we be able to get over 70, 80% when we open it up to every adult, over 18? I don't know, but certainly the older people were more than willing to get vaccinated. And the rollout, has really increased. We're doing about almost 2.5 million per day. And I realize our population is a quarter of your population. So you'd have to do 4 times that to go at that rate, plus other logistical issues that you have. But I would say overall, we had the worst death rate in the world. It shouldn't have been, but it happened for multiple reasons. It's very sad. But I think we're going to have rapid correction for vaccination. And then we'll have to watch the variants. Nobody can determine what will happen with that. And have everybody work together around the world on this. It's a world problem for everybody.
So did the injections continue at the same rate? Or,
yeah, by and large they did. By and large they did. We would call people and tell them, we think it's as safe for you to be here as anywhere. Safer than the grocery store. We know how to bleach. We know how to mask. We know how to do it for them. So we would have to talk to some of them, and we called up each and every one. So our staff were not working as much on other projects, in cataract or, in refracting people or whatever. So we had them call each and every person that needed to come in to reassure them, to answer their questions. And I think that helped a lot. Not 100%, but 85%.
So actually, we learned quite a bit from both of your talks. The second talk was more illuminating that AB study. I just wanted to ask about your views on steroids, because DME is thought to be a multifactorial. Apart from VEGF, there's a lot of inflammatory component also. About your personal.
Yeah, it's a good question. So first of all, if you look at the regimen I showed you, we showed you that following that regimen, if you're 20/25 or better, 85% end up 20/25 or better. It's tough to improve on that. It's darn tough. And if you're phakic and you induce a cataract, it's even worse. But if you're 20/32 to 20/40, or you're 20/50 or worse, and you've reached a point of stability, first of all, it takes a year to get to that stability, right? Because you do 6 injections. And then if there's still edema, not everybody has edema, but if there's still edema, then you might add laser, and then you might resume if it comes back until it reaches stability again. I think if you have somebody who's phakic and has stable edema, you don't want to touch them, because you're going to induce cataract in most of them. They have stable edema, so you're going to give them more than one shot of corticosteroids. And you'll eventually have to remove a cataract. And removing the cataract in the presence of persistent edema often does well, but in about a third of the cases does not do well. So what we do is we consider corticosteroids, but only in those cases that have gone more than a year, as I said, with these injections and laser, and they still have stable edema and they're pseudophakic, and they have to have some vision loss. They have to be 20, 32 or worse. We're not going to do it to someone who's 20, 25. And they have to have areas that we could laser. It might just be a central cystoid that's left. We're not going to laser that. So it ends up being a few people, but that's very few because they have to be pseudophakic. It has to be persistent. It has to be 20, 32 or worse. There have to be areas to treat. And that just gets to very few people. So yes, I think it's worthwhile, but in very few people.
And the other pertinent question was, a lot of these DME patients have coexisting cataract. So you want to stabilize DME first, then take on
Ideally.
cataract? Or
yeah, ideally. So you have to see how badly they need the cataract out. If they have both eyes are bad, they can't wait too long. And so then I would use aflibercept if you have access to it. That has the fastest rate of getting rid of the edema. And you don't want to do the cataract surgery if you can help it when there's edema, but you can't always help it. So sometimes you have to remove the cataract in the presence of edema, but you try to avoid it. You may have to tell the person, oh, you have some cataract there. We're going to take it out next year, and we're going to work on this edema until then. So we've got a long time to help you, but that's because we want to help your vision forever. 3 months, but forever. And so that's why. But I'll tell Dr. Himanshu, it's, these are advice and guidelines. It shouldn't be so absolute. This is what we've learned, and then you apply it each and every patient differently. Absolutely.
A question, Dr. Neil. Quite often we have found quite a few diabetics who had background diabetic retinopathy, and you do a cataract and they get into a florid state. Such diabetic retinopathy precipitates. Would you advise which are the candidates who might get in for that? Because the cataract surgeon takes the blame for this. Would you?
So certainly the ones who have edema. The ones who have edema are at risk. The ones who had HAD, had edema in the past, they're at risk too, because maybe you did laser or you gave them anti-VEGF. So you want to watch both of those groups very, very carefully. If they had it or they have it at the time, see them like 2 to 4 weeks later and jump in with anti-VEGF as soon as you can if you see it worsening in any way. The ones who haven't had edema, it's very unlikely. If they don't have a history or they haven't had it, it's very unlikely. That's good. They may get it a year later, which is part of the disease, but not because of the inflammation associated with the cataract surgery. And we don't find that adding corticosteroids or adding any drops is going to overcome the people that are at risk. So what you do is get rid of as much edema as you can, hopefully all of it, but watch very carefully the ones who had it or the ones who have it at the time you're doing the surgery and jump in with anti-VEGF right away. If they're pseudophakic after a year and it's not gone, you could jump in with corticosteroids as well, but not right away. You want to give the anti-VEGF a chance. It doesn't always happen after 1 or 2 injections. It sometimes takes 6 with laser on top of it.
Neil, what do you advise to a patient who has, uncontrolled parameters, HbA1c and blood sugar is haywire, but
very important.
Very severe edema? What do you advise?
Very, very important. So I'm not talking about the person who's in the intensive care unit with, fluid overload or something, but the people who are in bad control and are ambulatory. You want to get their control as good as possible, but in parallel to treating the vision. You don't have to wait to get things in control to treat the retina. You treat the retina in parallel to trying to get them under better control if you can. There's no need to wait. These drugs are so powerful. These agents are so powerful. They overcome whatever, you're going to get the hemoglobin A1C from 14 to 12 to 11 or something. Anyway, that's what we think. Now I'm going to have to go. I apologize. And it's late for you all too, but really because I have to get to our next meeting.
Thank you so much. Thank you so much for coming and joining us and giving such
Thank you all. Really. Always a pleasure. I look forward to seeing you over there. Okay.
Yes. See you soon.
Okay, bye-bye.
Okay, see you all soon. Bye-bye, everybody. Thank you. Bye.
Thank you so much.
Over to you, Rohan.
Yeah, so after that wonderful session on what's the latest in diabetic retinopathy, taking it forward, our next speaker, Dr. Lalit Verma, sir, he needs no introduction. He did his VR
Go ahead with the talk. I think the time is too late.
Yes, sir.
can just
Yes,
talk
sir.
about
Yes,
it.
sir.
So I thought we learned quite a bit from Neil Bressler. We can omit this talk and have some discussion. No? What do
So
you
you
say?
can just flip through it and then we can have a discussion and end it.
Okay. Let me see. So I hope things are visible there.
Yes, sir.
So I'll just try to rush because time is not on our side. Thank you, this youth wing, for having me here, and thank you, Pooja, for arranging the visit of Neil Bressler, because it was very illuminating. Although I've heard him 7, 8 times, but it's always you always become wiser. I'll talk something about PDR because DME is always controversial. PDR I thought is not controversial, and I also thank Himanshu and Amar and everybody for initiating. And I never knew that this is chapter 5. I still want to see what all you have done in 4 chapters. So till today, I still think that in PDR, whatever AB study may still say, laser is still the mainstay of management. And intravitreal injections, you see, you rarely get those non-resolving vitreous hemorrhages now, what Neil was talking about. You rarely get those vitreous hemorrhages. And I agree, if patient presents vitreous hemorrhage, and if you are very confident of your ultrasound, you may do that. Because ultrasound is a subjective kind of test, is an observer-based test. You can never be sure of those findings. So we laser, you see, not only HRC, we laser without HRC also, and sometimes very severe NPDR also. So PRP has been the treatment for not only PDR for decades and decades. It's not only now, since the DRS study demonstrated nearly 4 decades back. The confusion started once this anti-VEGF came, and this one of the DRCR study which compared PRP with the Rani Mizubab, and what they cleverly said was it is non-inferior to PRP. But what about situation like this? You see, this patient has very good vision. You see the huge number of massive fronts and a lot of non-perfusion. So I'm very fond of giving these biosimilars here. So I injected ranimizumab. This front shrunk, and then I did laser. So laser to me is the main stage for treatment for this. This was another patient, only eyed patient in a right eye, and you see the closeness of the fronts to the fovea. Fovea itself is enlarged. They're big fronts, very close to the fovea. This patient not been lasered, first time visit. Again gave ranimizumab. This repeated this effect just to show that this front has gone, absolutely gone. And then I lasered this patient. So I'll in brief tell about this IDDM, because IDDM worries me more than NIDDM, because there's a rapid progress in such. This lady, young lady, IDDM, working in a Google, company, irregular follow-up because the vision was good, because everybody saw it follow up, after 1 year, but this lady lost vision. And even at, 6/9, she had such rapid, proliferation if you compare from 2018. And once she developed a TRD involving, macula and nasal, then we operated during this COVID times only. This was the story of the other eye, equally bad, but we operated this eye first. Fortunately for me, she has 6/12 vision in each of the eye after surgery. But moral of the story is, I want to intervene much earlier compared to, you see, this is a story of another PDR patient who was intervened much earlier. And you see both eyes enjoy 6/6 vision. So I'll just, play a very short video and run through it. This is the video of that young lady IDDM who had florid PDR. And what Saurabh was telling, bimanual surgery still has a role, even though the port size has become smaller, or 10,000 cut rate has come. You see, this kind of surgery cannot be done without a bimanual approach. So I initiated this surgery trying to pull at the optic nerve just to initiate a small separation plane there. And once this separation plane was there, and you see all the retina is bulging into that, and then we had this cutter, did a lot of segmentation here because there's so much florid neovascularization and traction involving virtually all the quadrants, and very slowly try to trim these areas. We'll just run through it. These are difficult vitrectomies. They may take more than 1.5 to 2 hours. Then injected some PFCL to stabilize after I segmented this from the posterior pole. Still, there were a lot of fronts left, and this is the time when I started this bimanual surgery in this patient, inserting what Saurabh also said, the chandelier system, which has a role to play in this difficult diabetic vitrectomy, especially with the forceps in one hand and scissors in the other. Curved scissors is one thing which I will never start any diabetic vitrectomy without reassuring that curved scissors is available, because the precision with which this scissor adds to the cutting of these membranes atraumatically without causing a break, which cannot happen with cutters. And once this has been done, then you trim this, take care of other membranes here, do diathermy because that is very significant. I don't depend on laser for stopping the bleeding. Diathermy is a must. Diathermy is another very important instrument before we start a diabetic vitrectomy. And then ultimately you do a fluid exchange, laser all the iatrogenic breaks which you may have created. And fortunately this patient, and PRP has to be added totally. So we'll skip the other video. So vitreous surgery for me, threshold has gone down and sort of very nicely demonstrated a lot of applications of MIVS. We no longer wait, for weeks or months. Within 2 weeks, if the patient not doing well, we try to intervene. And non-resolving vitreous hemorrhage, at least in our practice, has become a very rare entity. Most of the patients are diabetic will present as macular TRD or a combined RD. So there's some of the pre-op and post-op patients of bad TRDs managed with the MIVS, which sort of described very nicely. The other patient fortunate to have 6x6 in both the eyes. This was another story of one-eyed patient. So outcomes are really improved with the kind of equipment which sort of showed very nicely with wide-angle viewing. Ultimately, believe me, all VR surgery is visibility. If you can see, anybody can do a good job. So PDR management in brief, I still believe laser is the mainstay, and good scatter laser, if you have done a good scatter laser without skip areas, has saved many eyes for many decades. Anti-VEGFs, I still feel have an adjunct role only, whatever AB study may say, because there's an issue of repeated injections, there's an issue of cost, there's an issue of multiple visits, and our population may not come back for all these things. Indications to me could be a recurrent small ooze despite laser with good vision, or posterior pole large front which I showed with good vision. These are the situations where I would consider anti-VEGF injections as a primary, but add on with laser also. And I still believe early MIVS, early PPV is relevant for long-term stability of these patients, because we should not and we cannot wait too long. Otherwise, believe me, these diabetic TRDs go very bad. And your aggression during surgery should be very calculated, because ultimately you want to help the patient, you want to give back some vision to the patient. Prognosis, as I said, has definitely improved. So thank you, Rohan, for being there and for asking me to be part of this wonderful symposium.
Thank you so much, sir. Your pearls really help us in PDR. Your experience is more important. Of course, these studies are ongoing, but you have seen in first-hand experience, how to treat these patients, and you know what works, especially in an Indian scenario. Thank you so much. I would request Dr. Himanshu, sir, to give a vote of thanks.
Dr. Mehta has left the talk. He had to go somewhere to see a patient. So.
Right. So, Dr. Lalit and Dr. Srinivas, sir, closing remarks, followed by Dr. Saurabh.
So I think, as I said in the beginning, the two talks which I enjoyed the most was one by Srinivas and the other by our young person, who has also left or who is still there.
He had network
He had
issues.
network issues, so he left.
Yeah. So by Devakant Misra, and talk by me was just a filler in the fact that I wanted to speak not on DME because I've spoken of DME and I have my reservations of managing DME because 1/3 or 30-40% of my DME patients still receive Ozodrex as a primary mode of treatment, irrespective of whether patients fake it or pseudo fake it. I don't care, but I still gave Ozodrex in at least 7 or 8 situations. And I also enjoyed Saurabh's talk because he had 7 wonderful videos and lovely videos every time Saurabh will show in all the conferences and a lot of learning.
Thank you, sir.
I would have loved to see Srinivas videos because for the first time when I visited Joshi Eye Institute, in Unity machine, I saw Srinivas, surgery there. And I didn't tell him that I was watching from behind. He did a wonderful diabetic surgery. I still remember Srinivas.
So you were sitting at the back, and I didn't even know. After the surgery, I got to know, and I was very thankful because if I had known before, then I don't know how many more iatrogenics I would have caused. So it was good. But he was just sitting in the back, and the whole live surgery, I didn't notice that. I'm really sorry, but in a way, it was good to me. It went well. Thank you, Lalit sir. You have always been very, very supportive for the youngsters. That is what I keep telling it, and I think we should all believe in that because I have seen him very closely. That he picks up the talent whenever he was the chairman scientific committee, irrespective of wherever you are, whether you're a youngster or whether you are based in an institution or whichever thing you might be in, but he tries to pick in the talent. That is one most thing which I like the most in Lalit sir. Thank you, sir, and keep supporting the youngsters. Thank you very much. Thank you, Saurabh. Thank you, Pooja and Rohan. You did a wonderful job, and keep continuing that so that it will benefit the many other youngsters. Thank you very much.
Thank you all for coming and being a part of this chapter.
Saurabh wanted to say something.
I just wanted to thank Rohan and Pooja and the youthful wing of IRSI to just continue what you're doing. You're doing a great job. I really enjoyed Lalit sir's talk, and from his talks we always get a very he has a point-wise presentation. It's always point-wise and it's very, very lucid, and I really enjoy his talks. And Srinivas, I enjoyed your talk today because it was totally different. So it was a nice symposium. I think congratulations to all. Thank you.
Thank you, sir.
Thank you all. We see you for the next chapter 6 of the Youthful IRSI web series, An Insight into the Mirror of Your Eyes. We would also like to thank our microvision team, Mr. Ashok and Mr. Navneet, for all their help at the back end through all these chapters and forward. Thank you all. See you all next month.
So my one request to Rohan and Pooja will be kindly publicize and advertise about your chapters because a lot of our residents were not aware of this. So I would request either put it on some Facebook, YouTube, or AIOS homepage wherever, because we would be keen to know more about what good work you are doing.
Sure. So we'll send you the links for the previous chapters as well. You can have a look and share it with your residents.
Okay. Thank you so much.
Thank you all.
Thank you.
Sir, your video was super. It's a wonderful demonstration for segmentation and delamination for the postgraduates and for the fellows. I really loved it.
Thank you so much. Thank you. Thank you. Bye-bye. Bye, Saurabh.
Bye.
Bye.
Good night.